Every surgery in a hospital depends on one critical factor: safe anesthesia. For surgery to be safe, anesthesia must be safe, monitoring must be proper, recovery management must be structured. But if anesthesia services are poorly organized, it can lead to airway complications, cardiac arrest, severe anesthesia drug reactions. These are life-threatening complications. That is why NABH introduced the COP-13 standard, which ensures that anesthesia services are safe, standardized and evidence-based. What you will learn in this video. In this video we will understand what NABH COP-13 standard says, what assessors check in OT for anesthesia services, common NABH non-conformities, how hospitals can become COP-13 compliant. Let's begin. What is NABH COP-13 standard? The COP-13 standard states, anesthesia services are provided in a consistent and safe manner. This means hospitals must ensure that anesthesia services are delivered using standard protocols, qualified anesthesiologists, proper monitoring systems. This standard does not apply to local anesthesia. Objective elements of COP-13. COP-13 includes several key elements. Standardized anesthesia services, pre-anesthesia assessment, PAC, pre-induction assessment, anesthesia-informed consent, intra-operative monitoring, post-anesthesia monitoring, recovery transfer criteria, documentation of anesthesia, infection prevention practices, monitoring of anesthesia adverse events. Assessors verify these elements through anesthesia records, OT observation, staff interviews. Standardized anesthesia services. Hospitals must ensure that anesthesia services are delivered consistently across all surgical procedures. These services should follow standard treatment guidelines, evidence-based clinical practices. Hospitals must also maintain written SOP describing anesthesia indications, type of anesthesia, procedure guidelines, pre-anesthesia assessment, PAC, before giving anesthesia. Pre-anesthesia assessment, PAC, is mandatory. PAC is conducted by a qualified anesthesiologist. PAC may be done before admission for elective surgery, before the procedure in emergency surgery. However, PAC must be completed before the patient enters the OT. Components of PAC. Pre-anesthesia assessment includes patient medical history, drug history, physical examination, risk evaluation. After PAC, the anesthesia plan is formulated. Anesthesia plan. The anesthesia plan may include premedication, type of anesthesia, anesthesia drugs, drug dosage. Additional planning may include special requirements, post-anesthesia care, post-operative pain management. Anesthesiologists must also review the patient's current medications. Pre-induction assessment. Just before induction of anesthesia, a pre-induction assessment is performed. The purpose of this assessment is to re-evaluate the patient's condition, verify the anesthesia plan. If the anesthesia plan changes, documentation is mandatory. In emergency cases, PAC and pre-induction assessment may be done together, but documentation must remain separate. Anesthesia-informed consent. Before administering anesthesia, separate informed consent must be taken. Anesthesiologists must explain risks, benefits, alternatives. Important point. Anesthesia consent is separate from surgical consent. Intra-operative monitoring. During anesthesia, continuous monitoring is mandatory. Monitoring parameters include temperature, heart rate, cardiac rhythm. Additional monitoring includes respiratory rate, blood pressure, oxygen saturation. Advanced monitoring may include end-tidal carbon dioxide, ATCO. Though all monitoring data must be recorded in the anesthesia chart. Anesthesiologist presence. During the procedure, the anesthesiologist must remain present throughout the surgery. This ensures continuous monitoring, immediate response to complications. Post-anesthesia monitoring. After surgery, patients must be monitored in a recovery room. Monitoring includes vital signs, level of consciousness. If the patient becomes unstable, they may be transferred to ICU for further monitoring. Recovery transfer criteria. Hospitals must define criteria for transferring patients from the recovery room. Examples include stable vital signs, adequate breathing, recovery of consciousness. Anesthesia documentation. Complete anesthesia documentation must be maintained. Patient records should include type of anesthesia, drugs administered. Anesthesia charts should also include name of anesthesiologist, assisting staff, Documentation must include date, time, signature, infection control in anesthesia. Anesthesia procedures must follow infection prevention practices. Examples include anesthesia circuit management, equipment disinfection. These practices reduce infection risks during surgery. Monitoring anesthesia adverse events. Hospitals must monitor anesthesia-related adverse events. Examples include cardiac arrest, endotracheal tube displacement, gas supply failure, air embolism. All adverse events must be documented, analyzed. This helps hospitals implement corrective and preventive actions. Common NABH non-conformities in COP-13. Common observations during NABH assessments include PAC documentation incomplete, anesthesia consent missing, monitoring documentation incomplete, recovery criteria not defined, adverse event monitoring system missing. Hospitals should address these issues to avoid NABH non-conformities. How hospitals can become COP-13 compliant? Hospitals can comply with COP-13 by developing anesthesia SOP, improving PAC documentation, standardizing monitoring protocols, defining recovery criteria, monitoring anesthesia adverse events. These steps help hospitals effectively comply with NABH COP-13 standards. In the next video of this NABH training series, we will discuss COP-14. Surgical services are provided in a consistent and safe manner. If you want to learn NABH standards step by step, then like this video, subscribe to the channel, turn on the notification bell, so you never miss upcoming NABH training videos. This is MediQuality Partners, your trusted NABH guide. Thank you for watching.